Some patients with AFib have a condition known as Bradycardia-Tachycardia syndrome. Dr. P, what is this condition?
Well, some patients have a difficult situation in which during normal rhythm, they have fairly slow heart rates. But during atrial fibrillation, the rates can be quite fast. Such an example is shown in this figure of a patient who has a slow heart rate during normal rhythm, but a very fast heart rate during atrial fib. And this, by the way, is a patient who is a marathon runner, and this is not infrequently something we see with athletes who have slow heart rates during normal rhythm. But if you look at the top, you can see a very slow heart rate. That's in the absence of drugs. If you look on the bottom during their atrial fibrillation, they're going really, really fast. I mean, in some cases, over 200 beats a minute. You can imagine that I'd have to use a lot of drugs to slow the bottom down, and they're only going to wind up slowing the top part down, making it extremely difficult to treat a patient like this with drugs only.
So in such a patient, how would you treat that individual?
Well, there are options to treat such a patient. One method would be to avoid drugs at all and just treat them with catheter ablation with the hope that they won't have the need for any rate or rhythm controlling drugs. Some patients just prefer to stay in atrial fibrillation all the time, and if you can control their rate in such a way, then it's okay to get away with that as another option, and that's okay. However, for many of these patients, implantation of a cardiac pacemaker is a successful method to allow you to treat the patient in a safe manner.
So Dr. P, how does a pacemaker go in?
If we take a look at this figure on the left-hand side, you can see this pacemaker is already in the heart. Typically, we put pacemakers in on the left side, but we can also put them on the right. When the patient's in the lab and they're heavily sedated so they're comfortable, we make a small incision in the skin and we find the vein, and as you can see from this illustration, the pacemaker wires go through this vein and they're positioned in the heart. In this particular patient, you can see that we have one wire in the top of the heart and one wire in the bottom of the heart, and they're connected to a pacemaker that is under the skin on the left side. That's the basic method that we put pacemakers in.
A lot of people are familiar with the term pacemaker, but we don't really understand how it works. Can you run us through that?
Sure. In this picture, it shows a pacemaker in the heart in which one of the pacing leads is in the top chamber and the other is in the bottom chamber. Now, if you look at the right side, you can see that there is a wire in the top and it's connected to the atrial tissue, and that's what that A stands for. In the bottom, there's a wire connected in the bottom of the heart of the ventricle, and that's what the V stands for there. It's in the ventricle. And you can note my little eyeballs there. So why did I put eyeballs in? Well, it's to represent the fact that these electrical leads see what's going on underneath them. In other words, they recognize electricity or impulses coming from the top if it's in the top chamber, and from the bottom in the bottom chamber. And the concept of a pacemaker then is it knows what's going on electrically in the heart, and we as electrophysiologists can set it up in any way we would like. So for example, if we want the patient's heart rate to be no less than 70 beats a minute, we'll set it in the pacemaker. If that little eyeball on the top doesn't recognize anything and it's slower than 70, it'll put an impulse in to run the electrical system of the heart. If a patient, for example, has heart block, then the bottom pacemaker will recognize no conduction has come to it, and it'll put an impulse. And by this situation, we now can restore the normal electrical flow of the patient's system. And then you can imagine then, if you now had someone who had a really slow heart rate like we showed in that patient before, we can use any kind of drugs we need to control them if that's what the patient wants, and we can maintain their heart rate at a very stable level so they won't get symptoms.
It's fascinating to see the diagram. What does it look like in action?
So I want you to take a look at this visual of a pacemaker actually in the heart. Notice there is a lead in the top chamber and a lead in the bottom. And what you're seeing is the top chamber, you see these little stimuli come in, and basically that's running the top chamber, and then what goes on in the bottom chamber will either be the patient's normal beat, or if they don't see a normal beat, it'll put one in. So you're seeing now the actual visual. If you were looking in, for example, in a fluoroscopic image in our lab, you'd see the heart beating in a nice normal manner. But it's done because these impulses from the pacemaker are running the heart. Lindsay, pacemakers are actually very sophisticated. They have features that allow us to change the heart rate if it's too slow or the patient needs it, for example, with exercise. In other words, they don't only just stay at the rate we set them at, they actually have internal circuitry and the ability to know when a patient needs a faster rate. So let's say a patient's exercising and normally their heart rate won't go up. The pacemaker can recognize that and actually get them to the level they need. And with a pacemaker in place, you can now safely use drugs that you normally couldn't do without them.
What about extremely difficult or unique cases?
Well, unfortunately, there are some patients who aren't candidates for catheter ablation, or they've failed it, they've tried it and failed, or they have the inability to take even some of these or any of the drugs that I've mentioned earlier because of side effects of the drugs, or the drugs have been tried and they've simply not worked. And they may also need to undergo then an aggressive procedure we call a blatant pace. And this refers to the destruction of the conduction system in the heart by a catheter ablation method that gives the patient a new problem, though. Now they have complete heart block. In such an instance, no impulses from the top of the heart can reach the bottom of the heart. But if you have a pacemaker in place, the patient's left now with a very regular rhythm due to the pacemaker giving impulses whenever they feel, whenever it's necessary, okay? An example of this is seen in this figure. You can see on the top is a patient that's not having any pacing and is in atrial fib, as you can see by all those rapid impulses on the top line. And on the next two lines are from a catheter that's in the actual bottom of the heart. And it's not too fast a rate, so it's okay. But still, this is the kind of person we might consider for doing the ablative pace if nothing else has worked. So this is a patient that had rapid rhythms. We couldn't control them. They were not a candidate for ablation. They failed drugs, and this is indeed our fallback. But this patient was now asymptomatic, feeling great, but they also have a new disease, right? We've created heart block in them, and so, in my opinion, this technique should be reserved for patients when other options for getting them better are simply not available.